Thank you, Steve. It's always a pleasure as a gastroenterologist to give a talk after everybody's come back from a full meal. I'm not sure if the pleasure goes both ways, depends on what you ate. But what I'm going to talk to you about today is a different way of looking at a disease that you're all familiar with, type 2 diabetes, and I'd like you to focus on the role of the gut by walking you through the evolution of our own thinking in some innovations that I will present today. So, I think. So you're familiar with these graphs. They tell a disappointing and distressing story. This is the rising prevalence of diabetes in this country. As you may have already heard, there are about 28 million Americans with type 2 diabetes, and 86 million of them in what we call the pre-diabetic phase. They're not yet classified as having the disease, but they're well on their way to becoming diabetic. It comes, of course, with a huge economic cost, but more importantly, if you think about these statistics, a third of all Americans will be diabetic if this trend continues. And this trend is not only relevant in this country. There are some countries and some regions of the world, such as the Middle East or South Asia, where the trend is even more alarming. 50% or more of patients, of citizens in those regions may become diabetic. So this is really a huge crisis and something that we need to do more than what we've been doing so far. Now, I think the first half of today was on weight management, and clearly there is a relationship between weight and diabetes, and this is what's driving the diabetes epidemic. I purposely used a very, very old slide because this was a paper that came out from the Harvard School of Public Health about 20 years ago, and has really set the stage for how we think about the relationship between weight and diabetes. You can see here on the x-axis is the amount of weight that you gain since you were 21 years of age, and with each 5 kilos, or roughly 10 or 12 pounds, your risk of developing diabetes rises. And within these categories, if you were already overweight to begin with, as you can see by the BMI, it rises even further. So if you gain about 20 plus pounds since you were at the age of 21, and your BMI is 24 or plus, then you have almost a 20-fold increased risk of developing diabetes. We also know that the principal mechanism by which weight gain, particularly the accumulation of what we call visceral fat, which is the fat around your visceral organs, your internal organs, is related to the development of insulin resistance. So insulin, as you know, is the hormone that drives sugars inside the cells, and insulin resistance refers to the phenomenon in which the cells don't respond as well as healthy cells do. So you need actually a lot more insulin to drive the sugars into the cells, which then results in rising sugar levels in the blood. So for a long time, this relationship has been recognized, and it has led to this so-called great debate. We must reduce weight. And until now, there were only two real choices, either pills, and we know that pills don't work very well for losing weight, or you put them on diabetic medications. And in the last 10 years or so, we also now know that there is a very effective surgical option for these patients. But it's a very drastic option, and this is gastric bypass surgery. You're familiar with this. People have talked to you about this. It's the creation of a small gastric pouch and then diversion of the food contents away from the rest of the stomach and the duodenum. And this is the area that is bypassed, and that's why this is called a bypass operation. It is extraordinarily effective in treating diabetes, not just weight loss. In the beginning, we thought the salutary effects on diabetes were due to the weight loss. But then we started noticing that patients were walking out of the hospital within a few days of their surgery, throwing away their insulin. This was before they'd lost even a pound of weight. And this is when the modern era of thinking about type 2 disease as a surgical problem started. So I'm not going to go into the details of these studies, but these are 3 critical studies that have shown that after gastric bypass surgery, 3 years later, for instance, 87% of patients could come off insulin. Similarly, other studies have shown equally impressive results. So what have we learned from this? To sum up a lot of the experimental literature, the take-home lesson is this is the critical piece of surgery responsible for the anti-diabetic effect. So bypassing the duodenum appears to be the most useful target for treating diabetes. If you exclude the duodenal wall from contact with food, so-called intraluminal contents, we can, in fact, treat diabetes. So this lesson has now been studied very well in animals, and there are some interesting theories as to what the duodenum, which is the first part of the gut after the stomach, is doing to control diabetes. We still are not completely sure. Work in my lab has shown that it's probably the nerves of the duodenum that are responsible for this effect. Other people speculate that there are as yet unidentified hormones, the so-called anti-incretins. Incretins are the hormones that help with the production of insulin, and this as yet identified anti-incretin is a hormone that works against insulin. And it is postulated that if the duodenum does not come into contact with food, then this anti-incretin is suppressed, and therefore you have an amelioration of the diabetes. But these are really theories, and I don't want to spend a lot of time on this because much of this work still needs to be done. Nevertheless, it has translated into some real practical solutions, even though we don't fully understand how it works. And one of the first successful devices that exploited this particular property was a sleeve. It's called an endobarrier made by this company, GI Dynamics. So they came up with this relatively simple, I would say brilliant solution. If all we need is to exclude that part of the gut from food contents, why go through surgery? Why not put a liner in there, essentially a sleeve? Food travels through that sleeve, does not come into contact with the lining of the duodenum, and may achieve the same effect as bypassing that part of the duodenum surgically. So, in fact, it worked, much to the surprise of a lot of us in the field. It worked, and it worked very well. It got approval in Europe, the so-called CE mark, which is the equivalent, rough equivalent of what the FDA does in this country. And then they started a pivotal trial here in the US to try and obtain FDA approval. And before I tell you what happened with that story, I just want to show you something that came off the wire this morning from the company. This is a result of their UK trial, just to illustrate how effective it is. This trial was a little different. They used it in combination with a drug that works for type 2 diabetes. And you can see with the combination of the sleeve and the drug, they had significant improvement in a variety of factors. So if you look at the number of subjects who had, at the end of 12 months, less than 7.5 units of hemoglobin A1C, which is considered very good. It's not ideal, but it's very good for type 2 diabetes. Nearly 50% or more of these patients achieved that goal, compared to only about a third of them, a third just on the drugs alone. So this is very good news. So you say, what is the downside, right? And the downside is that when they started the trial in this country, they had to stop it about a year ago. And they had to stop it because of the development of side effects. Now, there are lots of side effects of the sleeve, including some shown here, but the one that they had to suspend the trial for was a very serious side effect, what we call a liver abscess. So it was an abscess that occurred in the liver of these patients. So it was a focal collection of infection that occurred in these patients, potentially life-threatening, but certainly requiring intervention in the form of intensive antibiotics. So this trial had been halted because there was a very high number, unexpectedly high number of patients developing hepatic abscess. The company was a publicly traded company. It was down to its last few bucks, a few million bucks, I guess, but that's the same thing as far as these companies are concerned. They couldn't really run the trial. There was talk that this company would have a fire sale and basically go bankrupt. But apparently, they still have faith in this, and they're going to revive this, perhaps with some additional features that will make it safer. So this chapter is not fully closed, although it's somewhat disappointing. But in the next year or so, you might see this sleeve reemerge as a potential viable alternative. So we went from gastric bypass, major surgery, nobody really wants it if they can help it, to something that was much simpler, endoscopically placed sleeve. So this was not done surgically. Nobody had to get their abdomens open up. Just take a simple endoscopic procedure, pop the sleeve down, very appealing. And then this company in Fractal, which is started by a cardiologist, took it one step further. They said, well, maybe, it's not about excluding, well, it is about excluding the duodenal lining, but what if you just go to the heart of the matter and modify the duodenal lining? What if you induce changes in the duodenal lining that make it permanent, their inability to respond to food? And this is Fractal, and they came up with a relatively simple, even simpler procedure than the sleeve, which was to go in and literally burn the lining of the duodenum. And when you burn the lining of the duodenum, then the duodenum eventually does heal, and when it heals, they anticipate the so-called remodeling of the lining into a state which is no longer as responsive to food as it used to be, and therefore potentially mimics the effects of gastric bypass surgery. And they don't have controlled clinical data yet, but from their initial studies, it does appear that this might work. There are, of course, some risks to this because when you burn the lining of the duodenum, what you create is a duodenal ulcer, and so there are risks associated with that. How they can manage that, and whether or not this kind of remodeling that they're speculating on is actually sustained beyond a few months is also not clear. But it's an example of how creative people are getting now that they know what the target is. So here is the gap, right? So if you look at costs and you look at the efficacy in terms of the ability to reduce hemoglobin A1C, we have surgery right at the top. Very expensive, but also very morbid. I mean, lots of problems associated with gastric bypass surgery. Clearly, it's not an ideal solution for a variety of reasons. You have oral meds and insulin, which are relatively cheaper on the scale, but certainly not as effective. And then you have these emerging treatments that are still going to be expensive, require some kind of procedure, even if it's not surgery, and they may have side effects like we talked about and ones that I showed you in terms of the hepatic abscess. So here's a gap that needs to be filled. And of course, medical innovations like nature abhors a vacuum, medical innovation abhors a gap. So there are lots of people trying to fill this. What do we need to fill this gap? We need something that's actually completely non-invasive. Eliminate the specialist. We don't need to go to a gastroenterologist to get this done, or we don't need to go to a surgeon to get this done. Your GP should be able to deliver this treatment. That's another important requirement. But works the same principle as surgery. In other words, mimics surgery. Now, even if there's a trade-off, even if it's not as effective as surgery, but if it's simple, cheap, easy to administer, convenient, lots of people will benefit from that. So with that as background, I want to tell you a little bit about this company that I helped co-found, and this came out of one of the foremost schools of biodesign or courses of programs of biodesign in the country. That is the Hopkins CBIT program, which stands for the Center for Biodesign Innovation. Tom Donner, who's going to be speaking after me, was an advisor to this group of engineers who took this problem on, saw that gap, and said, we want to fill it. They came to me for potential solutions to fill this gap. And that's our team. These are what I call them kids. They're actually 25 years or older. Kevin, Pratik, Michael, brilliant kids, engineers, had no idea about biology, but knew they liked the problem and they wanted to solve it. And these are some of the other advisors on this team. So what is their innovation? What is Glycin's innovation? They said, okay, we need to exclude the duodenal lining from coming into contact with food. We've seen the problems with the sleeve. We don't like burning the duodenum and remodeling. Why don't we put the lining in a capsule? Why don't we just have the patient swallow and have the capsule release something that will coat the duodenum, not only coat it, but stick to it in a way that mimics the effect of the lining. And in fact, that's the essence of their innovation. So basically, it's envisioned as a once-a-day capsule taken each morning and filled with a fast-dissolving mucoadhesive polymer. So mucoadhesive means something that adheres to the mucous lining of the duodenum. And essentially, this would be a pill. But it'll be a pill without any side effects because this lining is not absorbed. This lining just sticks to the duodenum, and after a few hours or after 12 hours is washed out, and then you start all over again. So it's not really a drug. In fact, this will be classified by the FDA as a device because it's not really acting in the way a drug does. So here's what it looks like in an actual rat intestine. This was delivered via a tube placed in the rat's duodenum, and a few hours later, we tagged this polymer with a green fluorescent label so you can actually see it. This is the duodenum, here's the lining, and this is the polymer that is basically forming a sleeve, but a sleeve that was formed at the site of action, not something that was placed surgically or endoscopically. So we initially did some studies in healthy rodents to see whether it worked. And healthy rodents are very difficult to actually show an effect because they're not diabetic, but we were still encouraged by what we saw, that compared to controls, there seemed to be a flattening of the sugar levels after ingestion of a standard glucose challenge. This is your standard glucose tolerance test. And then we took this a step further, did this in diabetic rats. There is a diabetic rat called the Zucker diabetic fatty rodent. And this is one of the most commonly studied model of type 2 diabetes. And again, we saw a significant improvement in the sugar levels. And these are our most recent results. We've now reproduced this many, many times. And so what we have is a potential solution that mimics the effects of gastric bypass. The primary ingredient, like I said, is not absorbed in the GI tract, which is one reason it'll be treated as a device. And in fact, the primary component that we've used for these studies is has a GRAS label, which is, as you know, stands for generally regarded as safe by the FDA. So it may even not have been required much in terms of the regulation. So in conclusion, this is an exciting time for innovation, arguably one of the biggest medical problems in the world. Bariatric surgery has done us a great service, and it's often a crude start to what's truly innovative in medicine. It pointed us in the right direction. It has defined not only the gut as the primary target, but a very specific region in the gut, the duodenum, as being a key player in this potential solution for type 2 diabetes. And future innovations, including what I showed you today, will utilize this knowledge and provide access to an entirely new platform for tackling type 2 diabetes and really benefit millions of patients across the world. So I'll take some questions, but I just want to acknowledge our sponsors and partners who helped make this happen. A lot of the funding sources, National Science Foundation, NIH through its SBIR, STTR program, Coulter Foundation, and this, of course, is the program through which the students graduated. Thank you very much.